Hello and welcome today to the Hematology webinar series from Abbott on tools and techniques to optimize your hematology laboratories QC strategy. I'm Cassie Soltman of LabRoots and I'll be your moderator for today's event. I would like to mention that at the end of this webinar there will be a survey component. If you could please take a moment before you leave to submit your responses to the survey, that would be appreciated. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, report your problem by clicking on the Ask a Question box located on the far left of your screen. Today, our presenter, Maria Dosseh, will share her experience and expertise relative to quality control for the hematology laboratory. Maria Dosseh is the Associate Director of Quality Assurance for Streck LLC, an innovative medical device manufacturer in Vista, Nebraska. She is responsible for ensuring the competence and effectiveness of Streck's quality system in meeting customer requirements and international guidelines. Dosseh has a strong knowledge of both U.S. and international medical device quality system regulations and has audit experience, both internal and critical supplier audits. She also has a strong knowledge of the regulations and quality standards and quality control strategies for medical laboratory testing. Dosseh has spoken at Regional Clinical Lab Management Association events in Nebraska and at the Kentucky Society of MedTechs in Bowling Green, Kentucky. She has contributed to clinical laboratory articles published in Clinical Lab Products magazine and Streck product technical literature. Dosseh joined Streck in 2001 in the Research and Development Department and then led the Technical Service Department for 10 years prior to becoming Quality Assurance Manager in 2016. She advanced to her current position in 2023. She earned her Bachelor of Science degree in Medical Technology from the University of Nebraska Medical Center. Here are today's learning objectives. Review current quality control regulations and requirements. Discuss an optimal QC strategy and quality management plan. Determine target values and ranges for QC material using a simple procedure. Monitor ongoing quality assurance in the laboratory, and assess calibration and calibrator materials. And here are the required disclosures and disclaimers for today's presentation. It is now my pleasure to welcome Maria. Maria, you may now begin your presentation.
Thank you so much, Cassie, and thank you to all that are listening. I'm excited about this topic as I understand firsthand the role the laboratory plays in healthcare. And my hope is that you come away with more ideas and tools to add to your QC toolbox. Let's begin with a couple standards. ISO 15189 is Medical Laboratories Requirements for Quality and Competence. This was most recently revised in 2022. This document is used by laboratories to develop their quality system, to audit their process to ensure ongoing compliance, and it is also used by regulatory authorities and accreditation agencies for verifying the medical laboratory's compliance to those requirements. So it states, the laboratory is required to design internal QC procedures that verify the attainment of the intended quality of test results. The laboratory shall use QC materials that react to the examining system in a manner as close as possible to patient samples. QC materials shall be periodically examined with a frequency that is based on the stability of the procedure and the risk of harm to the patient from an erroneous result. And there's an important caveat that the laboratory should choose concentration of control materials that are at or near clinical decision values, which ensures the validity of decisions being made. So that requirement is to test the instrument or method in the same manner as a patient sample. And then in order to resolve that second bullet point and make sure we meet that requirement, we have to ask ourselves, how have we established that our procedure is stable? And what are our imprecision and bias goals? And have we defined those for each assay and parameter? The Clinical and Laboratory Standards Institute document C24 is Statistical Quality Control for Quantitative Measurement Procedures. It states control materials with assigned values provided by the manufacturer should be used only as guides and not as a replacement for target values and standard deviations established by the laboratory. The SD calculations for use in a QC strategy should be based on results for a long enough time period to adequately represent the types of influences and variables that contribute to the measurement procedure's long-term imprecision. So some of the influences and variables might include electronic noise, pipette performance, operator variability in pipetting technique, in mixing and handling technique, temperature and humidity controls, periodic recalibrations, changes in reagent bottles, lot numbers of reagents, and even periodic maintenance procedures, with these frequently occurring at longer time intervals. Hence the need to adequately identify these lab-specific situations that may lead to biological variation of an analyte. So where a measurement procedure may not be providing us reliable results, we want to make sure we have those checks in place to detect that. Hence, the manufacturer values become guidelines once again, and the laboratory implements hard upper and lower limits with corrective actions to take when those limits are exceeded. The CAP hematology checklist was also recently updated in October 2022. Section HEM 25850 states the laboratory analyzes 2 different stabilized control specimens during each 24 hours of analyzer use, with the caveat that stabilized control materials must be used at 2 different analytical levels, and there should be some relationship between the frequency of control runs and the number of patient specimens that we process. So best practices, if we're only following the minimum, is preferably a normal and a high. The reason for that is that a 10% calibration bias is numerically most apparent at your high-level QC, and perhaps inapparent in the lowest level QC. It'd be quite extraordinary for a low-level control to indicate a calibration problem that is not revealed by the other levels. Also, if a laboratory with a throughput of 40 samples in an 8-hour period were to encounter an out-of-control situation at the end of that shift, that's significantly less look-back time and labor to ensure that all runs reported prior to that last in-control event are acceptable, versus a laboratory with a throughput of 300 samples in that same time period. The Rillybach regulations are specific to Germany. There are other country-specific regulations, but we won't have time, unfortunately, to address them all. We will dive into this one a little bit. It states that the type and frequency of internal quality assurance and the specifications of the manufacturer must be followed. Control samples with target values in at least 2 different concentration intervals must be used. Each day of patient testing, control sample measurements must be performed at least twice within a 24-hour period, and at the latest after 16 hours. In addition, a single measurement of a control sample must be performed after every intervention to the measuring system. That includes after restarting the device once it has been switched off, calibration, after repair or maintenance work that is relevant to the methods test, and changing reagent lots. In addition, control samples must be as similar as possible to the patient samples being examined. They reiterate that control and calibrator materials must not be identical. And similar to past requirements that we've discussed, control samples with known target values should be relevant to the measuring interval for our medical decisions. Where the Rillybach regulations go above and beyond is that they require the laboratory to calculate the root mean square of the deviation of a measurement. This sounds complicated, but they do offer a table within that regulation for several analytes. As an example, for hematocrit measurements in a range of 10 to 60%, a root mean square deviation of 5% is permissible. So if the relative root mean square exceeds that 5% value, then that measurement procedure would be considered blocked from use until corrective actions can be made and that functionality of the procedure is restored and back in control. In the German regulation, 2 events in a row in subsequent control periods, or 2 months, would be considered an incident and warrant reporting to the German authorities. In the US, the Centers for Medicare and Medicaid, CMS, regulates all non-research lab testing through the CLIA Laboratory Improvement Amendment, or CLIA law, which requires a laboratory to perform quantitative tests using 2 control materials of different concentrations at least once each day patient specimens are assayed. So CLIA options include, first, that the laboratory establish the number, the type, and the frequency of the control material that they're using, and that they also verify the performance specifications. This control procedure allows the laboratory to immediately detect errors that occur during the test system failure and to monitor over time the accuracy and precision of that test performance that's influenced by changes in the test system. This type of approach is considered ideal as it considers the performance of the method as you select your statistical QC procedure and work to detect significant errors. The second approach states that at least each day of patient testing that specimens are assayed or examined, the laboratory perform testing utilizing 2 control materials of different concentrations. In my experience, this is the simplest and typically the default strategy employed. It is CLIA minimum. The last option, which was introduced in 2013, is CMS's individualized quality control plan. This plan is a bit more robust. It consists of an evaluation of a risk assessment, a quality control plan, a quality assessment program, and it's intended to cover the entire test process, meaning the pre-analytical, analytical, and post-analytical test phases. The Joint Commission is another accrediting agency in the United States. They state that each laboratory is required to establish its own control ranges by defining and having available statistical parameters. QC must also be performed when a complete change of reagents is introduced, when major PM is performed, after a calibration, and after any critical part that could influence test performance is replaced or repaired. James Westgard is the founder of multi-rules or Westgard rules, where data is evaluated on a Levi-Jennings control chart with control limits. He maintains the data from manufacturers is meant as a temporary workaround. And he states means, SDs, ranges, and other data from outside your laboratory do not reflect the individual particular conditions of your laboratory. So we see a pattern throughout the regulations, the requirements, and the literature that documents best practices. Not exact harmony, but there's a pattern. And what's the value? The value or end goal is a holistic approach towards control of pre-analytical, analytical, and post-analytical activities that are specific and unique to each laboratory. An effective QA and QC plan designed to monitor, detect, and eliminate errors that may cause patient harm ensures accuracy and reliability in patient results. So when it comes to defining QC frequency with patient risk in mind, where do we start? CLSI EP23 is another publication that provides an effective roadmap for designing, assessing, and implementing a statistical QC strategy that incorporates patient risk management through a quality control plan that serves to ensure the quality of our test results is adequate. That plan includes hazard identification, risk estimation and evaluation, implementation of risk control measures, documentation of our QCP, so that is types, frequency, and corrective actions when unexpected results are detected, and post-implementation monitoring. So this is a nice checklist of tools to consider, not all encompassing, as you can imagine, due to advances in technology, but it is a good starting point. Keep in mind that the process is iterative, meaning we have controls in place, then a failure occurs, we need to assess and identify if we have a new hazard, determine if there's an increased severity or frequency of that hazard for failure, meaning erroneous results. And then we work to implement additional risk prevention and control measures. Further, a robust quality management plan not only describes the statistical QC methods that were selected, but it also documents the risk management approach used to develop that QC strategy. So we evaluate probability, meaning how likely is the failure to occur, severity, how severe is the potential harm to the patient if the failure is undetected, and detectability, how reliably can our selected QC strategy detect that failure. And by limiting the frequency and severity of out-of-control measurement conditions, we ensure our role in preventing patient harm. Many factors weigh into our decision to purchase quality controls, whether that's purchasing from an ISO certified vendor, reliability of that QC material, performance, stability, cost, etc. The laboratory should select control methods that are sensitive enough to reveal loss of performance that could compromise patient results, but not overly sensitive to the point of indicating error where none exists. Also, control levels with concentrations at clinically relevant values are appropriate for monitoring performance and verifying suitability of results. So how do we ensure our QC is effective? A number of statistical tools are available. The well-known Westgard multi-rule QC uses a combination of decision criteria rules to help us assess out-of-control situations. We also have total allowable error, which is a quality goal that sets a limit for both the imprecision, which is random error, and bias, which is systematic error, that are tolerable or acceptable in a single measurement. So in that calculation, we take bias, imprecision, and a z-score. It's common industry knowledge to use 1.65. That implies that 95% of our test results will fall within a total error limit in our Gaussian distribution. The standard deviation index is another tool that helps us identify a systematic difference from the peer group mean. The SDI looks at lab mean minus group mean divided by the group standard deviation, where an SDI of 0 indicates there's no difference between the laboratory mean and the consensus group mean. This is a favorable condition in that bias is 0. An SDI closer to 2.0 would indicate a significant difference from that peer group mean and would warrant some review. Six Sigma is another helpful tool. This is most commonly employed in the manufacturing industry, but is still appropriate for the clinical laboratory, as Six Sigma is essentially an error rate. A little bit of background on this tool, as it's less well known in the clinical industry. In 1986, a Motorola engineer named Bill Smith, along with Dr. Henry and CEO Bob Galvin in that company, developed an idea and termed it Six Sigma. And this idea and approach is to reduce product defects. Six Sigma is a Greek letter and the symbol defining the standard deviation of a population. Essentially, it indicates 3.4 defects per million opportunities when we have the highest level of quality. Dr. Harry is often credited with adapting a martial art concept of belt rankings to Six Sigma, and that's where the Six Sigma Academy came about. The master black belt is typically the most advanced, while white belt denotes introductory level. And so today's Six Sigma focuses on reducing process variation and enhancing process control, whereas Lean Six Sigma drives out waste being non-value added processes and procedures, and it promotes work standardization and flow. For anyone interested in calculating these metrics, there are a number of online sites that have convenient calculators. Again, Lean Six Sigma, we're going to reduce waste, increase our process velocity. That's important when we talk about turnaround in the clinical laboratory. And it helps us assess our potential for defects in terms of per million opportunities, per million test results, et cetera. So how do we begin? When we first install a hematology instrument, imprecision studies must be performed. These initial standard deviation and coefficient of variation values are used to establish our short-term QC range. Next, CLSI offers a relatively quick and efficient way to establish initial targets. So C24 describes a process. First, we analyze control a minimum of 20 times across several days. Testing conditions during that time period should mimic routine testing as closely as possible. Those test conditions include temperature differences in the laboratory, inherent operator variability, recalibration events, even known biological changes to QC measurements or parameters over time. Next, we calculate the mean, SD, and CV. Most hematology analyzers are now equipped with QC files that help us quickly automate these calculations. And then that calculated mean should lie within the manufacturer's assay range. It's important to note that not all QC results need to fall within the manufacturer's published assay range, but the mean should fall within the laboratory's calculated range. So these become our evidence-based lab means and ranges. We could go into a discussion of QC multi-rules that is also outside the scope of this, but there is ample literature on westgard.com to help individual laboratories determine which rules are most effective for their laboratory procedure. Once we have those established, we talk about lot-to-lot comparisons. It's good lab practice and an ISO 15189 requirement to evaluate new lots or shipments of reagents and consumables prior to their use in reporting patient test results. So CLSI C24 offers a simple procedure to follow when transitioning to a new lot, beginning with setting up new QC files for each control level. So we're analyzing the current existing lot and the new lot side by side. You run each level once a day for 10 days to calculate that new lot mean. That includes, again, variables we've described before, different operators, different days, perhaps recalibration events, as much information and influences as possible to aid in the overall quality of our statistical data. We then compare those calculated mean values for each level to the prior lot means, and then we ensure that those means for the new lot are within the manufacturer's assay range. When we have an out-of-control condition, this means an intervention is needed. So our troubleshooting fund begins. And repeating measurement of QC material should only be used to rule out obvious problems with the material itself. We would stop auto-verification where that is in place to ensure that only accurate patient results are reported. And then our intervention examples could be calibration. It could be replacement of reagent containers, examination of our instrumentation, and then more in-depth root cause analysis if we're still not sure. Once those corrective actions are executed, QC is repeated, we verify the restoration of in-control condition, and then it's also important to look back to the last time the control results were acceptable and ensure prior results remain accurate. CLSI C24 states that quality control material should reflect the current condition of the analyzer. The expected values of our QC material may be influenced by reagent lot changes, minor maintenance, or the age of open controls. It's important to note that the laboratory should not make adjustments to QC target values until they have confirmed there are no changes to patient results. So spot checking a few patient samples run before those reagent changes or maintenance changes would be one way to accomplish this. It's also important to note that local regulatory requirements may preclude the laboratory from updating QC target values when a shift in QC results is noted. So that adds a little bit of a challenge. It's important to keep in mind that target values also come with ranges, and those ranges are based on historical data set specific to each laboratory. So we can rely on that data set to implement appropriate ranges. Let's talk a little bit more about when we can make an adjustment and the value that doing so provides. And this boils down to the reason we run QC material. So QC material is designed to closely resemble patient samples. It's comprised of stabilized cellular components, and that matrix is designed to be sensitive to and influenced by conditions that affect patient samples. And we want it to alert the user to such changes before it impacts patient results. Failure to update the target values when needed may introduce an artificial constraint that negatively affects the ability of the QC to identify shifts and trends. So applying too narrow of a limits or all-encompassing SD ranges for all test analytes and levels may lead to false alarms, repeat control testing, and that could lead to waste of control and tech time and reduced lab productivity. On the contrary, applying too broad ranges may lead to accepting too many results that really should be reevaluated for corrective action. To evaluate historical QC trends and determine if performance is as expected, it's helpful to participate in an ILQC program such as Streck Stats, and also proficiency testing or external quality assessment programs. While the latter are only a spot check in time, it's still a good idea to check for agreement with a peer group. We know that some parameters are known to increase slightly over the shelf life of the stabilized QC material. And a good example of this is mean cell volume. In the absence of changes that can affect the method, changes to QC results may be artifacts of that interaction between the QC material and our reagents or consumables. So as a great example of when we can adjust target values, we likely have historical data that shows as an example, a 2-unit MCV rise over the life of the control. Once we have that data, it's acceptable to raise that mean by half of this change to accommodate. For example, if our initial mean is calculated 84 and the historical 2 standard deviation is 4 femtoliters, then the laboratory can establish a target value of 85 with a range of 81 to 89. This cumulative mean calculated at the end of the product life should fall within the laboratory's established criteria. Both CAP, CLSI, international standards allow for means of a parameter that change over time to be adjusted. The key is to demonstrate this in the data set and to document the rationale. Again, this prevents unnecessary recalibrations for a measurand, which gives the laboratory back time, avoids waste, adds value. An important note regarding calibration. Calibrator materials should differ from QC materials to ensure that both provide an independent assessment of the system's performance. So utilizing just one level of our daily QC is not going to provide that independent assessment to ensure that our system has not shifted from zero bias. It's good lab practice for manufacturers to value assign and provide target values that are convened by transfer of whole blood reference values in their methods. And taking into consideration different software versions, reagent lots, system PMs, and hardware component replacements, all of these can be sources of variability. So that should be part of our data set that helps us understand whether or not we truly need to calibrate. This affords overall a more reliable establishment of our target values and standard deviations as we move forward. So over time, running QC material becomes a rote behavior. When we think about the patient waiting for their test result, we're reminded of the significance of reporting an accurate result. In summary, our individual laboratory evidence-based control ranges are built using performance goals. That means bias and precision of the test method is known, documented, and evaluated on a routine basis. They are specific to the instrument or method and level of control. Again, all with the idea to identify users of problems that warrant investigation, designed to identify issues, that we truly want to investigate, and they're not intended to be assay sheet limits or standalone rules. So in summary, they are scientifically valid. Quality control is one of the most important tasks that takes place in the clinical laboratory, and evaluation of our QC management and QC practices is an ongoing QA process. And with an effective risk-based approach, the laboratory can be confident in their patient test results. Thank you all for listening.
Thank you, Maria. We appreciate your time today and all the valuable information you have presented for our audience. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many questions as we have time for. Before we answer questions from the audience, we would like to acknowledge the support of the Streck by providing the speaker and the presentation for this webinar. Please visit Streck at www.streck.com if you're interested in learning more. So let's go ahead and get started, Maria, with our questions. Our first question that we have here asks, I can recall an ISO standard that mentioned a recommendation for using supplemental QC material from a different manufacturer than the analyzer. Can you comment on this?
Sure. So ISO 15189 actually still has that clause in 7.3.7.2. It does state the use of third-party QC should be considered rather than required. So consideration means documentation and justification for why one has chosen to remain with their current QC. Through historical data, you can effectively show that your QC is able to detect suitability in your system and verify your instrument or method's ongoing performance.
Great, thank you so much. Our next question that we have here states, we use the moving averages function on our hematology analyzer. Do you have any recommendations on how to use this as part of the overall quality control strategy?
Sure. There's a couple things that will be critical for onboarding and implementing such a project. First, some math. So we need to identify what calculations are important, which parameters do we want to measure, obviously which ones, identify the critical ones that we want tracked, and then establish criteria for what types of samples you also want included in that criteria for monitoring, and then your acceptance criteria. So what alarm triggers will then notify someone or alert someone that something has triggered a moving averages alarm, and corrective actions for what to do when that takes place. So a little bit of legwork up front to establish all of that, and hopefully a good software partner to help with creating that so it happens behind the scenes for the laboratory.
Fantastic, thank you. All right, our next question that we have here states, can you comment about QC complemented with retained whole blood samples?
QC complemented with retained whole blood samples. So meaning, if I interpret that correctly, meaning we're going to run QC per our minimum requirements in our local jurisdiction, but then also supplement with maybe a whole blood sample as a drift or a shift control. And that's, I've seen that historically. It can provide some questionable information, because remember that stability of the whole blood sample is very short in EDTA. So when we're talking specifically about hematology, it might be important to weigh the value of just running a little bit more QC, or alternating if you're going to do an additional QC run. Let's say a laboratory has 3 shifts, and currently the practice is to run control 3 times a day. by understanding your analyzer and knowing that there might be some shifts and trends that happen and you want to implement QC every 4 hours instead of 8, you might find that has greater value in detecting actual outliers than a sample that has a little bit less stability.
Great, thank you. All right, our next question that we have here from our audience asks or states, is it acceptable to use published insert ranges for hematology controls since the product shelf life is short?
Good questions, everyone. So it is acceptable to begin with the published assay ranges, but the regulations don't provide exceptions for not establishing individual lab means and ranges based on expiration dates. And again, it goes back to the criticality of that patient population and then monitoring the system performance to make sure that throughout that dating, there isn't something happening that would be an issue that you might not capture without specific target ranges. It also depends on the extent or the spread of that published range. You might find that it's adequate based on historical data, or that maybe it's too wide and it doesn't appropriately capture variation and fluctuations that you'd want to review and monitor.
Excellent, thank you. Our next question that we have here says, can you comment about the use of moving averages XB?
So that's very similar to the first question in regards to establishing a method for or implementing a method for moving averages overall. So there is value in that. As I mentioned, it requires some upfront work to establish a software, identify which parameters you'd like to track, identify how much movement would be acceptable versus how much movement from a patient result from 1 week or 1 month to the next would actually identify an issue. And it might require conversations with clinicians as you assess that information to make sure it's value add. And then again, the software and corrective actions, making sure you have the appropriate algorithms in place and then corrective steps for the laboratory to follow once those alarm limits are triggered.
Great, thank you. All right. Our next question that we have here says, our lab has been focusing on 6 sigma for our chemistry reagents. Do hematology reagents also have claims for 6 sigma performance?
I would actually consult back with the manufacturer on that one to see if they have any published literature for their reagents.
Got it, perfect. Okay, our next question here says, as stability of hematology QC is very low, still is it necessary to establish laboratory mean and range?
So if I interpret that question appropriately, I'm seeing that when we say stability is low, meaning there's not a lot of movement, that there is still value, especially when we talk about lot-to-lot correlation and comparison to the peer group mean. You may find in your laboratory that there isn't much movement without us performing some type of external assessment or making sure that we have tighter ranges in place to begin with. We're not sure if we're as accurate as we could be. So it's a ongoing iterative process, not only within the lab, but also a nice external check with the peer group to make sure that within our ranges and the target value that we see actually has consensus with the true or a peer group value.
Thank you. Our next question states, if we use manufacturers or published ranges, whether shift or trend has any significance.
So using the manufacturer's published assay ranges will make it harder to identify a shift or trend, because the sheer act of accepting that manufacturer's range, we know it's going to be wider. There's ample literature to show that an individual lab's SD and CV are going to be much tighter than any published manufacturer's range. So when a shift does occur, that shift may be subtle enough that it's still within the general published manufacturer range. Um, Yet, if the lab did have an individual lab specific mean and SD, that shift would be more pronounced in that lab specific SD and CV. That makes sense. So mathematically, that change would be more significant, alerting the lab to something that actually changed in the method or performance versus noise. That type of fluctuation might be hidden or missed when just the published manufacturer ranges are being followed.
Okay, great. Thank you. All right, our next question here asks, how can we use this QA and QC strategy in a low income and equipment constraint settings, hematology laboratory that does most of their work manually?
Good question. So assessing type, frequency of QC, it all begins with the criticality of the patient testing that's being performed, right? So you might identify what tests and what parameters are most critical for diagnostic to the clinician, and then have to increase your efforts in terms of statistical tools around that. So we've talked a lot about tools available online. There's some tools that are available that can help with graphing, with calculations. Um, so if I understand correctly, manual methods are being employed. You can still plug in some of that data in those spreadsheets and worksheets and have SD and CV calculations generated that can help you, determine QC frequency and have justification for less or more depending on which parameters you identify as most critical.
Thank you. All
You're welcome.
right, our next question here says, is it appropriate to use historically established SDs for lab range of QC for different QC lot numbers, so long as the rest of the system remains the same, i.e. same measurement, QC product, reagents, etc.?
Yes. And the answer to that is yes. So we have a process, right, for establishing initial target means and ranges. And once you have a few lots under your belt, your ILQC reports have a great tool within it that you can reference and evaluate the last 6 months or the last 6 lots, if you will, of SD and CV. So if there have not been any important changes, and you would know what those are. So significant changes in calibration that you notice a change in your QC material that's constant or consistent. You can utilize that historical SD to continue to use for your 2SD or however that math is playing out for you. But yes, those are appropriate and great use of historical data.
Great, thank you. Okay, we have another question here. It says, what should be the acceptance criteria for retained sample testing, lot-to-lot verification, inter-laboratory comparison, inter-instrument or intermediate method, comparison and repeat testing, CV or CLIA limits or TAE? If TAE, which one? If CLIA limits not available, then which criteria? What about biological variations within subject or between subjects? And we can definitely break that up into a few pieces.
Okay, that's a lot to consider there. It sounds like there. So you won't find the regulations say outright this is what you should follow. And as we saw and as we discussed, there's lots of information, but not clear harmony. So internationally and within the U.S., there are different guidelines and goalposts for total error, for acceptable variation. Biological variation is a great one to keep in mind. The thing that's consistent is the individual laboratory, establishing your own lab specific means and ranges. Once you have that, any lot to lot correlation that's performed, um, any other testing and criteria should fall back towards those established SDs and limits. That includes repeat testing. When we talk about comparison to a peer group, SDI is a nice, simple way to say, how is my lab? How different am I, or how close am I to the peer group for consensus? It's a nice way to keep gauge on how close you are to the peer group. Bottom line is there isn't anything cut and dry that says this is the magic number. It's up to the laboratory to identify what's the total allowable error you're willing to accept for any given test or any given parameter, um, and then to follow those requirements. Hopefully I've addressed that question effectively.
Thank you. Right. We have a question here that asks, can you throw a little light on the difference between validation and verification?
Sure. So manufacturers are required to validate products and medical devices. Onus falls on those manufacturers to perform adequate testing, collect data for submission to 510K for 510K approval. There is a significant roadmap for designing, assessing, evaluating, validating, and doing multi-site precision studies. When it comes to the laboratory, CLSI H26, specific to hematology testing, is a really great tool and roadmap that outlines the verification steps that the laboratory should follow just to verify that this method and these controls are going to be adequate for your system and method. So that might include verification that the QC performs as expected through expiration dating, verification of your lower limit of detection, lower limit of blank, imprecision, just understanding those goals and performance characteristics. Verifying that falls on the laboratory.
Fantastic, thank you. And it looks like we have one more question here for us today. It says the techs are divided on calibration, whether it should be with the calibrator recommended by the manufacturer or by whole blood calibration, or perhaps a combination of the two. Do you have any suggestions for us?
So I'm always a fan of what's most efficient for the laboratory. I would begin by querying the technicians that are on the fence about utilizing a manufacturer calibrator to understand their concerns. We definitely want every professional to feel comfortable. Manufacturers are required to maintain whole blood traceability when they value assign calibrators, meaning we are required, and other medical device manufacturers are required to ensure that the methods by which the white cell, the red cell, hemoglobin, hematocrit, and platelet values are assigned is traceable and anchored back to whole blood. So that traceability carries on to the end user and to the clinical laboratory. Many clinical laboratories may not have all of the necessary glassware and equipment that's required to do such a laborious manual whole blood calibration each time. For example, a spectrophotometer to measure light absorbance. So efficiency in mind, I think is part of the equation.
Great. All right. Thank you, Maria, for your time today. Did you have any final comments for our audience?
You're welcome. I hope everyone took away some nuggets, some tools. We're happy to share the slides. I know, Cassie, you'll describe that information. I've enjoyed talking about this topic. I'm very passionate about it. And if there are any additional questions that we didn't have time for, I'm happy to answer those offline as well.
Thank you again, Maria, for your time today and your important research and your informative presentation. We would also like to thank our sponsor. We would like to thank our sponsor, Abbott, for underwriting today's educational webcast. Before we go, I'd like to thank our audience for joining us today and for their interesting questions. Questions that we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. I'd like to take this time to remind the audience that there is an interactive survey that will display at the conclusion of this webinar. If you could please take a moment of your time to submit responses to the survey questions, again, that would be greatly appreciated. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Abbott will also host the on-demand link on our Hematology Academy website, available at www.hematologyacademy.com. Please also sign up for additional notifications on this site. Until next time, thank you and goodbye.
Thank you.